Good morning, everyone. Today I'll be speaking about a novel technique of creating temporal capsular access to counter negative dysphotopsia in cataract surgery. Dysphotopsia are unwanted visual phenomena which occurs after a routine cataract surgery, which can be a positive dysphotopsia in which patient complains of glaze and halo, and negative dysphotopsia in which patient complains of a typical arc-like shadow in the temporal field. The leading hypothesis for cause of negative dysphotopsia is the light which is incident from the temporal side on the nasal periphery of IOL creates a illumination gap which leads to this negative dysphotopsia. Our hypothesis is that if we instead of creating a central capsular excess, if we create a slight temporal capsular excess, we can eliminate this illumination gap and thus negative dysphotopsia. For this study, total 150 eyes were taken, 75 in the study group and 75 in the control group. We have kept the gender, age, type of cataract, anterior chamber depth, pupil size, type of IOL and surgeon all same to eliminate any confounding factor. And for each patient, one eye was operated with a traditional central capsular excess, and that eye was kept in the study group, and the other eye was, control group, and the other eye was operated with slightly temporal eccentric capsular excess, and that eye was kept in the study group. Follow-up for these patients were done on day 1, day 7, after 4 weeks, after 3 months, and after 6 months, and the incidence of negative dysphotopsia was noted based on history. So what exactly do we mean by creating a temporal capsular excess is shown in these photographs. These photographs were taken in the OT table. The surgeon is sitting on the temporal side, and we can see that instead of creating a central capsular excess, we have created a slightly eccentric temporal capsular excess. This is the photograph after the IOL implantation, in which we can see that the overall size of the excess has not been exceeded by 6 millimeters. So instead of being slightly eccentric, we have taken care that there is a 360-degree overlap of the anterior capsular rim over the IOL surface. Only the idea is that the nasal temporal rim should be broader than the temporal capsular rim. And this is the post-operative results that we have got, in which we can see that there is a clear decrease in the incidence of negative dysphotopsia in our study group, especially after 1 month of the surgery. So the incidence of negative dysphotopsia according to a long-term study is 15.2% on day 1, which decreases to 3.2% after 1 year of surgery. The reason for this decrease in the incidence is because of first is neuroadaptation, and second is because of the opacification of the anterior capsular rim, which eliminates the illumination gap. So our hypothesis is that if we will create a broader nasal capsular rim, it will opacify earlier and it will block a larger chunk of peripheral rays and thus eliminate the illumination gap and thus negative dysphotopsia. The advantages of this study is that it is very easy to learn, and there is no increase in the surgical duration or expenditure. However, there are few limitations that a long-term stability of lenses has to be studied. Then a larger study group, which involves the experience of other surgeons, has to be studied, and the diagnosis of dysphotopsia is based on history, so it makes it little subjective. But despite this, it's a very easy modification of the traditional method to counter a very frustrating complication. These are my references. Thank you.
What is the exact dimension by which you actually shifted for temporal capsular excess?
Ma'am, around 1 millimeter, ma'am.
1 millimeter.
1 millimeter. Yes, ma'am. We were not able to exactly control it that every shift is by 1 millimeter only. So we have defined a group, like the size of the rexes should be between 5 to 6 millimeter, and the shift should be between like 0.5 to 1 millimeter, not more than that, ma'am. Any rexes which is larger than this or the shift is more than this, then we have eliminated that eye from our study, ma'am. That exact shift and the exact rexes we were not able to control for each and every patient, ma'am.
But then in inclusion criteria, while you were evaluating the cases, suppose if you found that if it's not exactly matching your criteria, so did you exclude
Yes,
those
ma'am.
cases?
Yes, ma'am. We have excluded those cases, ma'am.
Okay.
What is the follow-up period for this?
Pardon me, sir?
Follow-up period.
Follow-up period, abhi we have followed these patients only for 6 months, sir. This study is still going on, and beyond 6 months, we haven't still, we are in touch with these patients, and we will be following this patient for another 2 years, sir, so that we can comment something on the long-term stability of the IOL, sir.
So an eccentric, little bit eccentricity to the capsular axis may lead to a disorganized capsular contraction force.
Yes, sir.
and that will be evident after, I mean, much after 6 months, maybe in 2 years. So that capsular contraction force may have a negative effect on this eccentrically enlarged
Sir,
capsular axis.
sir, we are keeping a tab of this. We are also recording astigmatism of each patient in each visit. So
Please
we can
follow
study
up
this.
for next 2 years
Right, sir.
and then publish another paper.
Right, sir.
Thank you.
Right. Thank you, sir.
Sir, ma'am, any question?
No.
Sir, any question? May I call upon the next speaker, Dr. Ankita Singh.
Good morning, everyone. My topic is on posterior keratometry changes after steep axis phacoemulsification. So presently, it is a generation of a refractive cataract surgery where everybody wants emetropia. In our study, we have tried to find out the influence of the posterior corneal astigmatism on total corneal astigmatism, because so far, due to the primitive devices which were existing earlier, only the effect of anterior keratometry was taken into the consideration while calculating the surgical induced astigmatism. So the study was done at a tertiary care eye hospital, and it included the 60 eyes of the consecutive patient with age-related cataract, and they all underwent uneventful phacoemulsification surgery at the same institute. The inclusion criteria included the patients with age-related cataract, regular astigmatism by topography, and no existing preocular pathology. The exclusion criteria included any cataract other than the age-related, any history of trauma, contact lens wear, corneal scars, or any opacification which would have affected the visual outcome. The patients underwent the complete ocular examination, and the keratometry was evaluated on the anterior as well as focal posterior corneal surface at 3 mm, 5 mm, and 7 mm respectively. And the parameters subsequently were used to guide the steep axis emulsification. Then later on, the anterior and posterior corneal astigmatism, they were defined as per with the rule, against the rule, and oblique based on the steep corneal curvature. Post-operatively, the patients were followed up, and after 1 month, the data was taken into consideration. So these were the results. Out of the 60 patients, mostly the average age was 60 plus, and mostly male patients were there. And out of them, 39, that means 65% patient had pre-existing against the rule astigmatism. The overall result which we saw was there was no significant decrease in the anterior corneal keratometry, whereas there was a decrease in the anterior corneal astigmatism. Whereas when we saw the posterior corneal curvature, at the focal points 3 mm, 5 mm, 7 mm, there was a decrease in the keratometry values. However, there was an increase in astigmatism. So, as per the conventional practices, only the anterior corneal astigmatism was corrected. But by the Steinfluck imaging system, now we can take into the consideration of the posterior corneal curvature also. And the studies have already been started publishing, which have shown that there has been an effect, and there has been focal steepening because of the effect of the emulsification on the posterior corneal surfaces. Now, this was a single follow-up study, and there was a small population, so this has its own limitation. Probably a long-term follow-up study will be required to conclude the concrete data. So based on the result of our study, we can conclude that the steep axis may have a larger impact on the posterior corneal surface than it was actually thought. And it may clinically impact the more precise manner of post-operative cataract surgery planning and astigmatism correction. These are my references. Thank you.
What is the period of follow-up till now for this study?
Ma'am, this was 1 month, ma'am.
1 month.
1 month.
So it's too short, I
Yes,
think.
ma'am, it was
isn't
true.
Regression will start after 3 months.
So,
Anyway, there is called on-axis phacoemulsification. The term is not steep axis phacoemulsification. It's called on-axis phacoemulsification.
so.
Anyway, have you quantified your incisional size?
Sir, it was 2.8 mm and it was biplanar, sir.
Have you quantified
Yes, sir.
on that incision planning the incisional size, because according to the astigmatism, preoperative astigmatism you have found, because it has got a very important role. You cannot make only a standardized incision for all sorts, all grades of astigmatism. Higher the length, longer the incision, more is the flattening, is not it? more anterior is the incision, more is the flattening. These certain rules are there.
Sir.
Have you gone for that?
So far we have not done that, sir, but yes, sir, it should be taken into consideration.
Okay.
Only one surgeon. The same surgeon, we have followed the data of the same surgeon, sir.
Ma'am. May I call upon the next speaker, Dr. Pavitra Patel.
Good morning. Just 1 second. The format is not correct. It's shifted. The things have shifted. हाँ? अभी चेक किया तो बराबर था ना, ये हिल गया पूरा। ठीक है, चलेगा चलेगा। Good morning, everyone. I'm going to present my poster podium presentation on duoplater, a novel instrument for toric IOL alignment in small pupils. I have no financial interest. So to begin with, we are all aware of multiple preoperative and intraoperative causes of insufficient pupillary dilatation and the challenges which we face because of this, mainly which can include blind rhexis, posterior capsular rupture, vitreous loss, nucleus drop, zonular dialysis, retained cortical matter, damage to the iris tissue, and the most challenging of all, toric IOL alignment in small pupils. So how can you tackle this situation? By various methods, most common being pharmacological dilatation. But again, it has contraindications. It cannot be used in patients who are hypertensive, who have known cardiac conditions, and who are allergic to these drugs. Then we have a method of mechanical dilatation. This is a very good way to increase the pupil size, but intraoperatively, when you get a Meo's pupil post-nucleus removal, it is really a time-consuming process, and it can result in sphincter tear, and it has a learning curve attached to it. And then there is this newly launched intraocular lens marker by Dr. Sri Ganesh. Again, a very good marker, but the indentation mark on the IOL does not stay longer. So then the aim of the study was to demonstrate the applications of duoplater, which is a novel instrument for simultaneous stretching of the pupil and toric IOL dialing in cases of intraoperative Meo's pupils. So this was a prospective interventional study which included 120 eyes of 65 patients. Now all patients undergoing cataract surgery with phacoemulsification with a monofocal toric IOL who developed intraoperative meiosis were included in the study, and all these patients had an axial length of less than 25 millimeters. All those patients who had a preoperative non-dilating pupil or were known cases of IFIS, uveitic cataracts, traumatic cataracts, had known retinal pathologies, irregular corneas, were all excluded from the study. Now, the preoperative evaluation included the routine cataract evaluation, what we do for all our patients. Now, because I couldn't put the video as this was poster podium presentation, I will just show you how the instrument looks like later after the presentation. So this has a fulcrum here, which is basically, which helps to push the iris, and then there is this dialer tip which helps in dialing the IOL to its desired axis. Now, because it has two purposes, it serves two purposes, the term duoplater was coined, and all the surgeries were performed by a single surgeon. So the follow-up protocol was at day 1, week 1, and 1 month. These are the patient demographic data pre-operatively. Now, the graph 1 shows the degree of misalignment. Now, all the patients, 120 eyes, had a degree of, the misalignment was less than 10 degrees at the end of 1 month. This is the graph 2 post-operative uncorrected visual acuity. Again, at the end of 1 month, 112 eyes had a UDVA of 6/6, 7 eyes had a UDVA of 6/9, and only 1 eye had a UDVA of 6/12. Graph 3 showed distribution of the residual astigmatism, and all the eyes, 120 eyes, were under less than 0.5 residual astigmatism. Sorry. Now, post-operative inflammation, 94% of the eyes had shown no signs of post-operative inflammation. And the last graph shows the percentage of iris damage. Again, 95% of the eyes showed no iris damage in any form. So to conclude, This instrument saves on time. It can be used under irrigation. You don't need viscoelastic substance. It is a useful and a practical instrument with a very short learning curve, and it has a good safety and feasibility in various hands what we have studied. Thank you.
Okay, since you haven't put up the video, can you explain just in few words how do you use that duoplatter?
So basically, just 1 second. Can I come near?
Sure.
Can I come near?
Sure, sure. As you wish. Yeah, understood. Understood. How do you to use it?
The midpoint
Understood.
between the two, it helps to push the iris behind, and then with the dialer tip, like any other dialer, you rotate the IOL to its desired. So you push and you rotate. You see where is the IOL marking. You see first by pushing the iris everywhere, and it's not too harsh that you are pushing and you are damaging the sphincter. So you push and you see where exactly, and then you dial. So that is and this can be done basically once the nucleus is removed and the pupil has gone down to a very smaller limit.
Okay, since it has got a small fulcrum, if there is amount of intraoperative meiosis is more,
Yeah.
suppose it's fully dilated, fine enough, that will hold it a little bit of iris. If the intraoperative meiosis is more, means more of iris needs to be pushed back.
Yeah.
Will it work?
Yes, the dialer tip is of 0.9 millimeters, so it works even in very small pupils. It's longer than the normal usual dialers.
Okay.
It is 0.9 millimeter, the tip.
So is there any chance that dialer tip may rupture excess margin? Because
There
when
is-
you are pushing iris, the dialer tip is like this and it is 0.9.
Correct.
0.9 is quite big.
Correct.
Is there any chance that it will rupture?
It might obviously, but we didn't face. Obviously, you have to be little careful while using because it's slightly longer than the normal dialer tip. It has definitely a chance of that, but being, safely, if you do it, obviously it doesn't really rupture the anterior capsular.
Complications can always occur. That is there. They are trying it. Thank you.
Thank you.
May I call upon the next speaker? Any Dr. Neha Hemendra Shah.
So my topic is, I'm Dr. Ajay Dudani. So my topic is any single piece foldable lens can be converted into a transscleral tuck lens. So PCR in vitreous loss always comes unannounced. Anterior vitrectomy is done, but if there's a very poor posterior capsular support where you can't put the lens on the rexis, you can't always keep a battery of IOLs ready as a follow-up in this patient, especially with odd power IOLs like AC IOL, iris claw, 3-piece. Hence the need for a method where any single piece IOL can be converted into a scleral tuck lens. The principle is creating a transscleral plug on an haptic for scleral support. So you can deliver to your patients what you promised, a premium IOL, trifocals, EDOFs. So this is the inspiration which I got for this thought which I had in my mind. The Carvalhale lens, which has got a transscleral plug which holds the IOL in position in patients where there is deficient posterior capsule, and the CMT flex lens which is there available in the market. So this is the worst kind of lens which you have a rent where you can't put this on the sulcus. The only extra thing is you need either a 40, 50 or a 60 Prolene suture in this case. So this is how the lens is fashioned. It's a single piece lens with a Yamanization of the haptic, like you create like a dumbbell sort of a 50 Prolene outside the eye rather than doing it inside. So you have a lens which you have created on the table when you have that complication, and you can create these two bulbs like that here. And one bulb will hold the haptic inside the eye and the other one is exteriorized to give a support in the transscleral support this is. So this is a surgical technique. You mark the limbus at 3 and 9 o'clock, limited peritomy. You make an angled incision of the sclerotomy with a 23 gauge MVR blade. So you create a tunnel where you can tuck that dumbbell inside post-op. So you have a flanged, the IOL which you have created, you can inject it over the iris because the PC is absent. Then each transscleral plug is exteriorized with a 23 gauge max grip vitreous forceps. And the laxity is adjusted by further dumbbellizing by using extra cautery. And then you can co-opt the peritomy with diathermy. So this is how one of the first cases I did when I was learning this thing. This was the 3-piece IOL which has gone into the vitreous after 10 years of surgery because the proline haptics do degenerate over a period of years. And this is the, one second, sorry. So this is how we created the IOL, you know. So this is the video which is showing that. So this is the 3-piece IOL here, as you can see, with the you know, the transscleral suture IOL, and this is how you create the dumbbell. And then this IOL is injected into the anterior chamber.
In their dressing, they had the strongest.
So this is just showing you a brief video. So once you've created that IOL, this is how we extrudize the haptic here. Can you see that? It will come out. And similarly on the other side you could do that. And this can be further. So the other side you can similarly do that.
Go away.
Usually I use a AC maintainer or a vitreous infusion, and then you can further create the dumbbell and push it inside the scleral tunnel which you have created. So this is how it looks post-operatively. So what I have thought that with the industry assistance, if you could create a banding sort of a thing, you could create a device like that where you could have it in your OT, and any lens you can, you know, feed this sort of this device here, the transscleral plug device, and convert your IOL into a transscleral plug IOL. Thank you very much for your patience.
The IOL, what you retrieved from the vitreous,
Yes, sir.
it seemed to have broken haptic
Yes, sir.
at some part.
Yes, sir. In that I didn't reuse the same IOL. We used this separate
Okay.
IOLs.
Okay,
was
I
just to
thought
show
you
you.
used the same IOL.
No, sir. We used the separate IOLs.
Okay.
Yes, sir. Thank you.
May I call upon the next speaker, Dr. Tusidhar? He's absent. Then may I call upon the next presenting author, Dr. Anusa KS?
Good morning everyone. Today I'll be talking about efficacy of a novel technique, anterior chamber dialer divide for soft cataract management by phacoemulsification. Nowadays we are encountering soft cataracts more frequently due to increasing patient awareness, early identification and referral, evolving lifestyle requirements which are bringing patients earlier to the hospital. Soft cataracts are characterized by minimally dense endonucleus of spongy consistency with abundant sticky soft cortical material and well-developed nuclear cortical back adhesions. Hence, removal of this type of cataract poses difficulty. Phaco within the capsular brach are prone to complications such as PCR, corneal endothelial damage, nucleus drop, zonular dehiscence. For all these conventional techniques to be performed safely and efficiently, an advanced phacoemulsification equipment is necessary. Not always there will be access to such advanced equipments. Therefore, we are describing a novel technique, anterior chamber dialer divide, for which an advanced phacoemulsification equipment is not necessary, and also for an efficient and safer nuclear fragmentation of soft cataract. Objectives of this study was to analyze and compare the intraoperative performance, postoperative outcome of soft cataract surgery performed with ACDD technique and conventional phaco. So it was a randomized comparative study with a sample size of 100 patients. We included nuclear color grade of 1 and 2, opalescence grade 1 and 2, cortical cataract of grade 1 and 2, posterior subcapsular cataract of grade 1 and 2, and with anterior chamber depth of more than 2.5 mm. And patients with pre-existing glaucoma, PXF, chronic uveitis, retinal pathologies, patients with traumatic cataract, complicated cataract, and patients with comorbidities like diabetes mellitus and hypertension were excluded from the study. All the patients were randomized into 2 groups using a lottery method. and patients in group A underwent novel ACTD phaco, and patients in group B underwent conventional in the back phaco. Intraoperative parameters like ultrasound time, effective phaco time, BSS volume utilized, surgeon's comfort were all analyzed, and follow-up was done for 3 months. About the technique per se, a 2.2 mm clear corneal incision with 1.2 mm side port was made, and capsulorhexis of 6 to 6.5 mm was done, and 2 dialers were introduced into 2 opposite side ports, one above and one below the nucleus in the same plane up to the edge of the nucleus, and nucleus is divided by simultaneous upward movement of the below dialer and downward movement of the above dialer, thereby cutting the nucleus into 2 halves. So the parameters were ultrasound time. In the group A, it utilized less time when compared to group B, and the difference was statistically significant. Endothelial cell count loss at the end of 3 months in group A was less when compared to group B, and it was statistically significant. Central corneal thickness was increased in group B in the immediate post-op, and at the end of 3 months also it was statistically significant. Macular thickness was increased in both the groups. It was not statistically significant, and it resumed the preoperative values at the end of 3 months. To conclude, ACTD allows easy and fast emulsification of soft cataracts. It has better surgeon comfort. It neither requires specialized instruments nor higher-end phaco machines. It also utilizes less phaco time and energy, thereby less damage to the corneal endothelium. Thank you.
What was the grade of these cases? Grade of nuclear sclerosis?
Sir, 1 and 2.
1 and 2.
Yes, sir.
And what was the age of these patients?
Sir, it was less than 50, sir, 50 years.
Young patients.
Yes, sir, young
Okay.
patients.
For soft cataract, do you need all this difficult instrumentation? Because that is going to increase the chance of complications more, no?
Yes,
What is your opinion?
Intralenticular manipulations, when you can do a very nice aspiration of the center and then tuck the nucleus so nicely in a single flip.
Sir, in our setup, we have a peristaltic AMO compact phaco machine, sir. Yeah.
That's a good phaco machine. No.
The video which you showed, that it fractured with the 2
Yes, ma'am.
dialer, but when it's very early soft cataract in NS1, it's not easy to fracture it. The only one video have. Please collect all your cataract cases, and so if it comes out so nicely, it doesn't happen actually.
This was not a soft cataract. The
This was
video
not the
has
one.
shown 2+.
Yes.
Okay.
Anyway, it was a nice presentation.
Thank
Okay.
you, sir.
May I call upon the next speaker, Dr. Jatinder Singh Bhalla? Is he absent? Okay. May I call upon the next speaker, Dr. Kabya Khatri? हाँ, उसमें absent लिख दीजिए.
If they come, they can come.
Okay.
Good morning to everyone present. The title of our study is Intraoperative Complications in High Volume Cataract Surgery, Quartile-Wise Analysis. To meet a backlog of 3 million cataract size, we have finite clinical.
Please reset the time and you start again. Please reset the time. Okay, you start again from good morning.
Slides change nahi ho rahi.
It's not good getting forward?
No,
Oh. Don't panic, huh? Don't panic. It happens. We are in an electronic age.
Yes, start.
Delhi NCR. Ma'am, private medical college में ना? ज़्यादा valuable.
Yes, go ahead.
Good morning to everyone present. The title of our study is Intraoperative Complications in High Volume Cataract Surgery, a Quartile-Wise Analysis. To meet a backlog of 3 million cataract eyes, we have finite clinical resources. High surgical volume leads to inevitable mental and physical fatigue and lapse in concentration. This leads to intraoperative complications. Current literature shows significant association between the number of surgeries performed by a surgeon in a single day and the occurrence of intraoperative complications. This, however, is in contrast to the annual incidence of capsule-related complications. This tends to be lower in surgeons with high or very high volume setups when compared to moderate or low ones. We conducted a retrospective cross-sectional study from January to June 2023. We considered manual small incision cataract surgeries which were performed by experienced surgeons. The time of surgery was divided into four quartiles. The first quartile being surgeries that were performed from 7 a.m. to 9 a.m. The second from 9 a.m. to 11 a.m. The third were those that were performed from 11 a.m. to 1 p.m. And the fourth were those that were performed 1 p.m. onwards. Not only did we look at the quartile of occurrence of complication, we also did an in-depth analysis about the type of complication, the visual acuity on post-op day 30, whether or not resurgery was done, and if there were any post-operative complications. A total of 19,206 cases were performed in the 6 months period. In these, we encountered 281 intraoperative complications. The quartile-wise analysis showed that the maximum complications, that is 33.4%, was seen in the third quartile, that is in the 11 a.m. to 1 p.m. time period. The individual type of complication, when we looked at, we found that most of them were in the majority in the third quartile, while some were equal in the third and the fourth quartile, and some were seen maximally at the end of the day, that is in the fourth quartile. 35 patients had to be left aphakic in this time period. Among these, the maximum were in the third quartile. Among the patients who had good visual acuity, that is 618 or better, the maximum were in the second quartile, while those who had poor or average visual acuity, the maximum were in the third quartile. Among these complicated cases, 21 cases required resurgery and 50 cases ended up with post-operative complications. Both of these were encountered maximally in the third quartile. So, surgeon fatigue leads to poor decision making and compromises patient safety. Surgeon fatigue, however, is a modifiable risk factor. Making the surgical team well aware of their roles and responsibilities will lead to a hurdle-free surgical day. Pre-operative planning and scheduling of the more difficult cases in those quartiles, that is quartile 1 and 2, where there are likely to be fewer complications, will be very valuable. Some of the methods to reduce surgeon fatigue include getting good sleep the previous day, taking micro pauses intraoperatively, as well as well-timed breaks, taking care of nutrition and hydration in these breaks, as well as practicing meditation and stretching techniques. Current literature shows the importance of taking well-timed intraoperative breaks. However, there's no emphasis that has been paid to the quartile of operating hours yet. In conclusion, we found that the surgeries that were performed in the third quartile, that is in the 11 a.m. to 1 p.m. time period, encountered the maximum intraoperative complications. Not only this, among these complications which were encountered in the third quartile, the resurgery rate tended to be higher, there were more post-operative complications, and the visual outcome tended to be poorer. These are my references. Thank you.
May I ask one question? Did you analyze the type of surgeons who were assigned to do surgery during 11 a.m. to 1 p.m.? Is it the juniors have been left behind and no, seniors are there during the lunch period? Is it because the reason behind the complications?
Ma'am, the very junior surgeons don't operate for the entire day.
That way
So
everybody
we-
understand.
yes,
What
ma'am.
I'm asking you, in your case,
Yes,
did you
ma'am.
analyze the profile of the surgeons who were left behind at between 11 a.m. to 1 p.m.?
Ma'am, most of the surgeons start in the morning itself at 7 a.m. to
Same
operate.
surgeon, you mean?
Yes, ma'am. It is not so that only the...
Then going by the fatigue criteria, it should have happened in the last quartile, isn't
Yes, ma'am.
it?
That is...
So how do you explain why?
Yes, ma'am. That is because most surgeons take a lunch break at 1 p.m. From somewhere between 12:45 to 1 p.m., they take a half an hour lunch break. So the fourth quartile is post that. Post
So,
lunchtime.
so for all the slots, the same surgeon.
Yes, sir. Most surgeons start operating at 7 a.m. in the morning and stop by roughly 3:30 that time period.
Okay. So,
Around 30, sir, 30 to 40. Over different, it is a data collected over 6-month period. So total surgeons would be 30.
High volume surgery, you told.
Sir,
What do you mean by high volume surgery?
who are performing a very high number of surgeries per
High
day. ma'am.
means what numbers? Because in a particular day you cannot exceed.
Uh,
What was that
the
number?
maximum number, ma'am, would be
No, it's not like that.
on average it would be at least 20 to 30 cases, and the maximum would range up to 50 cases.
Every day,
Not
same
ev-
set.
That is not high volume.
Every day, same set of team is working, doing surgery.
Not every single day, ma'am, but on every surgeon goes
Then,
to the OT twice a week.
How you differentiate which day is more having more complications? So maybe na day this surgeon's day is having more complication in this period of time, 11 to a.m.
Yes, ma'am. We did not do a surgeon-wise analysis.
So it is also important, na?
Yes, ma'am. Right. Manual small incision cataract surgery, sir. The charitable side. Yes, sir. Yes, sir.
what is the period, what is the slot in your hospital where the fellows and, postgraduates are given the cases to do?
We start in the morning, sir, at 7 o'clock.
They start doing operations since morning?
Yes, sir. Yes, sir. The days when there are a higher number of cases, we start at 7 a.m. right itself. Otherwise, 7:30 to 7:45.
Individual surgery by the postgraduates in the morning?
Yes, sir.
Okay. Okay, fine.
May I call upon next speaker, Dr. Rasik Priya Sandhu? Please help her out.
Yeah, I want to start. Good morning, everyone. I'm here to talk to you about the long-term outcomes of Sioni ring back fixation in subluxated lenses. There are no financial interests. Loss of substantial zonular support leads to difficulty in lens removal and subsequent implantation of an intraocular lens in both children and adults. Nowadays, cataract surgeons have a multitude of options in their armamentarium to facilitate an IOL implantation. These include a scleral fixated IOL, glued IOL, Yamane technique, AC IOLs, and many others. However, one of the main advantages of using an endocapsular device is that we manage to preserve the capsular bag. That is, we maintain the physiological compartmentalization between the anterior and the posterior segments of the eye. We do away with the need of a vitrectomy and possibly any vitrectomy related complications. Most importantly, we get to place the IOL in the most anatomical position, which is the capsular bag. Also, another major concern in these eyes has been the biodegradation of the suture material. Since this capsular bag is sutured to the scleral wall using the suture material, the degradation of this material can lead to late decentration. This is of grave importance because most of these patients are young patients with a very long lifespan ahead, and in addition they can have comorbidities such as Marfan's, homocystinuria, which predispose them to progressive zonular weakness. By now it is well established that 10-0-proline undergoes biodegradation. Therefore, in our study we used 9-0-proline. Our own group itself has been involved in the study and analysis of these eyes, but a restriction of the previous studies has been that they have been confined to a period of say about maximum 5 years. To the best of our knowledge, there are no reports in literature with a follow-up of more than 9 years. This was a retrospective observational case series, and all eyes underwent an MCTR fixation using a 9-0-proline. Subluxations of any etiology were included, and only those cases were analyzed where we had at least a 5 years post-operative data. So, looking at the results, what did we see? This cohort included 41 eyes of 31 patients. The mean age at surgery was about 20 years, with a wide range of 4 years to 50 years. It is very important to know that children, that is, below the age of 15, accounted for almost 60% of the eyes in our study. Not surprisingly, Marfan's was the most commonly identified etiology in about 40% cases, and in about another 40% cases, we could not identify any underlying cause. The mean follow-up was close to 10 years with a maximum range of 20 years. Most of the eyes, about 90%, received a single eyelet CONE. The patients were measured in the CDVA and the incidence of post-operative complications. It is very heartening to see almost 3/4 of the patients had a best corrected vision of 612 or better, and only 10% had vision less than 660. PCO was the most common complication seen in about 41% eyes, and all underwent a NDR capsulotomy about 1.4 years after surgery. 7 eyes required a surgery for late decentration. In 4, we could refixate the original IOL bag complex using a Gore-Tex, and in 3 eyes, we had to explant and have a secondary IOL. It is not just pediatric eyes, but also adult eyes that undergo decentration. Therefore, all these patients need a very good preoperative counseling for the secondary surgery. This is the patient who underwent surgery, but say that the total biodegradation, the bag is dead stable. RD was seen in 4 eyes, about 10%, and 3 of these eyes already had a preoperative diagnosis of Marfan syndrome. In addition, in conclusion, I would like to say it's a very skill-dependent procedure, but we should not be disheartened because the results are very satisfying. Thank you.
Have you done anterior segment OCT in a long post-operative period?
No, sir, we didn't do any OCT. That was not one of our outcome measures. We identified them on the CDVA and the incidence of the post-operative complications that I showed.
You are not interested to see the CONE ring behavior?
Sir, we did UBM for certain cases, like one of the slides that I showed. Post-operatively, whenever the patients would come at the scheduled visits, an UBM was done to see the centration and the placement.
Now, your very topic says, topic dictates that all the cases should have the assessment of the position and functioning of the CONE's ring in the long term because you have used the long-term outcome of Sionist ring. So it has to be assessed.
Okay, sir.
Okay. In your next series, you assess the UBM or anterior segment OCT for all the cases. It should be a protocol.
Yes, sir. So the UBM that I showed, UBMs are done for all these patients.
You have done for all the patients.
For all the pediatric patients that came in,
Oh.
because we have a separate day for pediatric ophthalmology.
In that
Okay.
case, if your data is stored in computer, you can always go back and review what sir suggested.
Yes.
So you can add up once, it will add value
Yes.
to the study.
Yes,
The
because
data
that is very important,
Yes,
because
sir.
you have given the term long-term outcome following Sionist ring bag implantation.
Patients.
So that should be documented.
Right, sir. Thank you.
May I call up our next speaker, Dr. Mayuri Pathak?
Good morning to all. My topic for today is comparing clinical outcomes of different EDOF IOLs. EDOF IOL is a new technology in treatment of presbyopia correcting lenses, and it primarily improves intermediate visual acuity, which is useful for computer work, while providing good distance vision. Based on IOL technologies, it is grouped as spherical aberration-based pinhole effect, wavefront shaping, diffractive and refractive types. They bridge the gap between monofocal and multifocal IOLs and cause less unwanted optical phenomenon like glare or halos than the multifocal IOLs, and offer improved contrast sensitivity. The aim of the study was to analyze visual outcomes after bilateral implantation of 3 EDOF IOLs, that is Vivity, Eyehance and Magnificent. Objective was to assess the binocular uncorrected visual acuity for distance, intermediate and near, to assess clinical performance of each IOL by measuring the contrast sensitivity and photic phenomenon by dysphotopsias questionnaire. Patient satisfaction was measured with the help of visual function questionnaire and Presque questionnaire. It was a retrospective study conducted at Lakshmi Eye Institute, Panvel for a duration of 12 months, and the total number of patients included was 67. All the patients 18 years and above who were diagnosed with bilateral cataract and underwent elective cataract extraction with IOL implantation by phacoemulsification were included. Any patient with irregular or asymmetrical astigmatism, presence of any corneal, capsular, zonular and pupillary abnormalities, any retinal or optic nerve pathologies, intra and post-operative complications were excluded. Post-operative data abstraction was done, and binocular uncorrected and corrected distance, intermediate and near visual acuity was measured at 1 month, 3 months and 6 months. Binocular defocus curve and contrast sensitivity was also taken at each visit, and the 3 questionnaires were taken at 6 months. So the results, binocular uncorrected visual outcomes for distance showed that all 3 EDOFs gave satisfactory results of 0.18 logmar or better, and out of the 3, Vivity showed better results with 0.04 logmar at 3 months and 6 months. All the 3 IOLs gave decent intermediate vision of 0.3 logmar, which was constant over 6 months, and out of the 3, Vivity gave better results with 0.2 logmar, which was statistically significant. Vivity also showed near vision of 0.4 logmar, while other IOLs showed lesser acuity. The defocus curve at 6 months for all the 3 IOLs showed that Vivity had the broadest defocus curve, extending from +1 diopter to -2 diopters, which translated to a near add of 1.25 diopter. The clinical performance for all the 3 IOLs showed that majority of the patients did not have any photic phenomenon, and out of the 3, Vivity group showed better results, which was statistically significant. All the 3 IOLs gave decent contrast sensitivity, which was comparable to that of monofocal IOLs, and no significant difference between the 3 were seen. Coming to patient satisfaction, most of the patients in all 3 groups said that they did not need glasses for intermediate vision, and majority, that is around 80% of the patients, were comfortable without glasses and never or only occasionally had to wear glasses for intermediate vision. Most of the patients were either extremely satisfied or satisfied, and none of them were disappointed or distressed in either of the lenses. And according to Visual Function Questionnaire 14, it gave good patient satisfaction with a score of 99 out of 100. So to conclude, visual outcomes for all three EDOF IOLs give satisfactory distance visual acuity, decent intermediate vision for routine life, and out of the three, Vivity showed better intermediate vision with a wide defocus curve and had the least visual disturbances, and contrast sensitivity for all the IOLs were comparable to that of monofocal IOLs. Patients implanted with EDOF IOL had high self-reported levels of satisfaction along with substantial reduction in spectacle dependence. Thank you.
A very nice presentation, but do you think spectacle dependence is an universal thing, and or is it a customized phenomenon? I mean, it varies from individual to individual. Demand for good near vision, demand for good intermediate vision, it varies from individual to individual.
Yes, sir, but cataract surgery is now.
So most commonly we compromise as a cosmesis.
Yes, sir. So for the people who want spectacle independence, previously the option was only monofocal IOLs, which caused visual disturbances and glares and halos. So by using EDOF IOLs, they give good intermediate vision and decent and somewhat good near vision, and that can without the photic phenomenon which is seen. So it improves the quality also as well as the spectacle independence. We had to compare all the three lenses work with different optical principles. So we wanted to see which optical principle in EDOF performed better, which we found was Vivity, which worked on wavefront shaping. Sorry?
So they have not taken trifocals, they have not taken monofocals, they have taken only the enhanced vision. Now this is a very small small sample. 67 nowadays, with having so many enhanced monofocals getting implanted, 67 is a very small one, but every small study has got importance, and getting that these are not, I mean, whatever the companies claim, actually everyone is same. That is also good.
Actually, they say IONS is not a EDOF lens, it's a modified monofocal lens.
Yes.
It's not a true EDOF lens.
May I call upon next presenting author, Dr. Shruti Revankar?
Good morning, everyone. Okay. I'm Dr. Shruti Revankar, and I'll be presenting the visual outcomes in bilateral implantation of trifocal lenses with asymmetric light distribution. We know that cataract surgery has evolved over time, and so have the patient's expectations. All want a quality of life which they enjoyed before the aging process of the eye started, and to have an active life without being troubled by the use of spectacles. So how do we promise this to the patients? We have the single monofocal lenses which provide a very good distance vision, but they do not help in intermediate or near vision. Then we have the extended EDOF lenses that help in distance as well as intermediate vision, but do not help, the near vision is the downside. And then we have the bifocal lenses which help in distance and near vision, but do not help in intermediate vision. So to bridge this gap between monofocal and the bifocal lenses, the trifocal lenses were introduced, which generate a true intermediate focus, helping intermediate distance and near vision. So we studied one such new generation IOL, that is the geometry range of IOLs. We have two models in this. One is the geometry and other is the geometry plus. Both these models have a near IOD of 3.5 and intermediate IOD of 1.75. So how do these models differ? It is basically because of the difference in light distribution between the two models. In the next slide we can see, not showing. Okay. So basically the geometry lens, it provides a very good, excellent distance vision and a good intermediate and near vision. and the Geometry Plus, it provides an excellent near vision with good intermediate and near distance vision. So when we pair this by placing Geometry in one eye and Geometry Plus in the other eye, it causes pairing of the light distribution because of the complementary light energy distribution profiles, and it results in an excellent near as well as far vision and a very good intermediate vision. So this is the percentage of light distribution between the two lenses. So the aim of our study was to evaluate the safety, efficacy, functional vision with bilateral implantation of these two lenses. It's a prospective single-center study. We studied 52 eyes of 26 patients. There were no intra or post-operative complications noted, and all patients underwent flax. And we have a 2 weeks follow-up available. So we can see here in terms of binocular distance unaided visual acuity at 2 weeks, 98% of the eyes had 6/6 or better vision, and all eyes had a 6/9 or better vision. We also studied the near visual acuity, where all the patients had a near visual acuity of N6 or better, and some of them, like 39% of the patient had a vision of N5 also. The spherical equivalent lied between -0.5 to +0.5 diopters in 94.23% of the patients. We also studied the reading acuity and reading speeds using the Salzburg reading desk at 40, 66 and 80 centimeter at 2 weeks. We can see in the first graph, the reading acuity was better than 0.1, which corresponds to 7.5 Snellen's equivalent at 40, 66 and 80 centimeter. And also the reading speeds at the same distances was more than 150 words per minute. The defocus curve, we can see that there are 3 elevations, one at 0, the second one around -1.5 and third one around -3, which corresponds to the distance, intermediate and near visual acuity. And also the contrast sensitivity testing using the fact charts was better than, lying between the normal range in the graph as seen here. We also studied the patient satisfaction score and spectacle independence using the modified type questionnaire. So the patient satisfaction score was 9.54 out of 10, which was quite good. And spectacle independence was seen in 100% of the patients for all the distances, that distance, intermediate and near. To conclude, pairing the lenses is pairing of Geometry and Geometric Plus lenses provides a continuous range of vision, high quality vision for spectacle independence from distance, intermediate to near, and also pairing is the most balanced combination for high spectacle independence from far to very near. Thank you.
Although the study doesn't give any major scientific contribution, it's a well-known fact, but the method of the study and statistical analysis, everything is very good, excellent, and the study was conducted well.
Thank you, sir.
In this session, we have seen presentations from very renowned institutes, at least 4 or 5 renowned institutes. But the originality and scientific contents contribution from these studies are not as I had expected, or as expected by everybody. I think we can, because all these institutes can provide more logistics, more infrastructural assistance, we should come up with some better scientific contributory things. This is only my view. I leave it to chairperson.
Hello, good morning, everyone. Students, you have really done wonderful job. I appreciate your hard work. These are all going to improve in future, I'm sure. Whatever you have done, brilliant work. Maybe all of you will not be a winner, but for you, you are a winner because you have your hard work is really appreciable. I appreciate. Thank you.
We had two absentees, Dr. Jatinder Singh Bhalla and Dr. Tusidhar. Have they come? Or, sir, we will conclude this session. We'll conclude it. All presentations were very nice, nicely presented. Thank you.